Good afternoon, everyone. I am Misty Hicks, and I am the co-founder of Wonders and Worries, and I'm also the director of the Registered Wonders and Worries Provider Program. And I am thrilled to welcome you to our April Wonder Chat. As usual, before we get started, I am going to go through some housekeeping things before I turn it over to our presenters for today. If you've been on one of these before, you know that we don't use the chat feature, but we do use the question and answer feature. So if, as Crystal and Laura are presenting, you have some questions, go ahead and type them in the chat. I'll moderate those and either drop them in like while they're talking or put them at the end. So I'll be monitoring that. Crystal, if you want to slip to the next one for me. So evaluations, those are so important to us. I would look at those, and we've made some changes that I'm going to tell you at the end of this presentation based on feedback. So an evaluation, when you sign out of this webinar, the evaluation will pop up on your screen. If you can complete that, we would certainly appreciate that. If you don't get to do it today, it will also come in an email that comes to you tomorrow as a follow-up. So you don't have to do it twice, but we would certainly appreciate one of those evaluations. Regarding the PDU process, for our Wonder Chats, you're always welcome to listen to them for professional growth and development at no charge. But if you do need PDUs, then you would listen to the webinar. At the end of this webinar, I'll have a QR code that'll take you to the site where you can purchase the post-assessment. Or you can just go to our website and purchase the post-assessment. So you purchase that for a nominal fee of $10, you take the post-assessment, and then the certificate gets emailed to you. Crystal? So today we're talking about assessment, and I know this is a topic that so many of us are so interested in, and we need those PDUs as well. So I'm thrilled that Crystal Wilkins, who is our Director of Programming at Wonders and Worries, who, if you've been on these before, you likely have met and heard from before. So Crystal will be with us, and Laura Chalk from Cook Children's, who's a child life specialist in the ER, is with us as well. And I'm especially excited about this duo because we have two perspectives. So one who's been longer in the field, they'll tell you a little bit about that, and one who's a little newer to the field and how they look at the assessment piece. And then also two different settings, an outpatient sort of setting and a hospital-based setting. So I think it's going to be such a nice dynamic to hear from these different perspectives as we walk through this presentation. So I'm going to go ahead and turn it over to Crystal and Laura. Thank you both for being here, and I'm looking forward to hearing what you have to share with us.
Thanks, Missy. Happy to be here. And as Missy said, I am a Director of Programming over operations at Wonders and Worries. I've been at Wonders and Worries now for 5 years and have been a child life specialist for 18. I also work as a licensed professional counselor and registered play therapist at Austin Stone Counseling Center, which is a counseling practice here in town. And so as we go through the presentation, I may be flipping my hat and talking from a child life perspective or a counseling perspective, and I'll make sure that I share that. But I'm going to pass it to Laura to be able to share a little bit about her experience. She's not a newbie in a child life world. She's very seasoned, but she was one of my first and best interns. And so we go way back, and was colleague and friend for a number of years, and she's near and dear to my heart. So Laura, tell us about you.
My name's Laura. I am a child life specialist, and I've been a child life specialist for about 6.5 years. So I've worked here at Cook Children's Medical Center for about 2 years in the emergency room. And prior to that, I worked at Children's Health in Dallas for about 4.5 years. And that included my fellowship experience and 3.5 years in their emergency room.
All right. So I'm just going to kind of frame up our presentation a little bit. As we're talking about assessment, we're going to talk about it from different lenses. So we'll start out just providing some different definitions from different therapeutic disciplines. As Missy said, we're going to be talking a little bit about assessment in a very fast-paced acute setting like the ER. Laura has worked in the ER her entire career, and so she's very well versed in that. And then I'll be speaking more from a chronic care perspective. And then we'll talk a little bit too about clinically, what does assessment look like when we're first starting, and then what does it look like as we develop more skills, I always think of assessment as like developing your intuitive gut of how do I make decisions with clients. And then we'll wrap it up with some examples of clients that we've worked with or patients we've worked with in the different settings that we both work. And so from a definition perspective, Merriam-Webster defines assessment as the act of making a judgment about something. And judgment, that word, can get a bad rap. Judgment, oftentimes we think it's somebody being judgy, but in this perspective, it's being able to gather information in a way of making a decision, making a therapeutic decision, as it is with the roles that we play. And so I was talking with a kiddo recently, 13-year-old boy that I see as a counselor, and he was talking about how he takes in information and how his personality, how he copes with things. And he was talking about being an ISTJ on the Myers-Briggs personality assessment. And as we were talking about what each of those letters meant, he got to J and was like, oh, that's kind of a bad thing. And I was like, no, actually, it's a great thing, because you can make decisions probably pretty quickly. You're able to take in information and just go boom, 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 like that's what I need to do. And I said, I'm a P, but I used to be a J, and kind of taught him about the continuum and talked about the different things that were going on in my world. When I was a J, I worked in the ER, and now I work in chronic care. So I don't know how much that influences even our personalities and ways of being, but I think it could. And so anyways, hopefully was able to help him recognize his personality was just fine. But some other key pieces of assessment, it can be formal or informal. It's an ongoing process or series of interactions. It allows for prioritization. And so from a therapeutic standpoint, that can mean determining what needs to happen first, second, next for a client. And so it can help you kind of determine the sequencing of the care that you want to provide for a client. But it can also help you tune into what's most important to this client. Like, what is the pressing concern right now? What are they focused on? What are their values, to where you can address those needs first, and then get to the other things that you may see, but they can happen later. And so that prioritization can kind of happen in a different way. And then again, it helps create effective intervention planning. I'm going to pass the baton to Laura to talk a little bit about the child life perspective of assessment.
So when thinking about assessment, there's many different ways to make an assessment, and that can vary based on your role, the population you're working on, in the setting you're in. So we just kind of wanted to touch on each different way that we kind of use, our approaches we use to make assessments. So kind of like Crystal touched on, it can be a formal assessment, and there's different tools that can be used. I think for child life specialists, this is less likely to be the case, but mental health professionals, this is something that's used more often. For child life specialists, we kind of work, my goal, especially in the ER, is to figure out the most important information I need to make my interventions the strongest for patients and families. So observation is super important, observing what's happening in the room or with the patient ongoing. Conversation with patients, families, and the medical team. So before I go in a room, I'm trying to gather as much information as I can about this patient to help me maybe avoid the parents being questioned or asked to repeat things that maybe has already been shared to the nurse or the provider. So that the medical chart also comes into play there. I can pull that up quickly, see kind of what their history is like. What was their chief complaint when they came in the ER? What was shared during that triage process that could help me entering that room to avoid asking the same questions. But then coming up or formulating questions that can help spark my intervention planning. And then obviously play is super important. In the ER, again, that's a little bit different and isn't a super long planned out process, but utilizing toys that maybe the kid already has in the room, or quickly doing some medical play during the preparation to help engage that patient, build rapport, and allow that patient to maybe express their concerns when words are not typically their way of expressing their language. Sorry, my bad. Moving on, we just wanted to touch a little bit on the different professional councils that we fall under. So looking at the ACLP, we kind of pulled up that values statement that they offer. And in that statement, it says that the services provided by child life professionals will be evidence-based, developmentally appropriate interventions that include therapeutic play, preparation, and education to reduce fear, anxiety, and pain. So even though that statement doesn't say assessment, assessment is the component of how we'll accomplish and uphold those values. That is how we make our clinical decisions and make those plans appropriate for each individual child.
Awesome, thanks, Laura. And this is the ACA Code of Ethics, the American Counseling Association, and it says something very similar. And so again, we just put these definitions up there to recognize that this is a key entity in how we do our job and how we do it well. And so whether you're a counselor, a social worker, a child life specialist, and you're tuning in, this is a key skill and a key expectation in your job functioning. And then assessment for clinicians that are counselors or licensed mental health professionals. Oftentimes assessment and diagnosis kind of go hand in hand. Not always, depending on the theoretical orientation that you ascribe to. You can do assessments and not diagnose. I, as a child therapist, I really try not to, especially because the counseling populations that I work with a lot of kiddos who've experienced trauma, and so different diagnoses can look very similar. And so I choose not to unless it's absolutely necessary and it's for the benefit of the client. But specifically for clinicians that are doing reimbursement and that sort of thing with managed care, that can become a little bit trickier. And so, so assessment and diagnosis can go together when you are a licensed mental health professional, but as child life specialists, that's not something we do. We work from a preventative scope of practice. If you like to be funny, I try to be funny, not always. Or if you like a good meme, here you go, this is for you. I always joke that sometimes my career is killing my dating life. For those of y'all that are married or have children, it might seem the same way. If you're constantly assessing and people are like, are you psychoanalyzing me? These are just some funny memes addressing that. So maybe try to turn off that assessment lens when you go home, but it's very difficult. So if you do, we all do. That's fine.
Okay, awesome. So I want to kind of touch mostly on how to make a quick assessment. So because I work in an emergency room and that's a very quick interaction I'm having with patients, just touching a little bit more on that so that Crystal can then touch on the more chronic or long-term assessments and how she does that. So for me, when I was thinking through making assessments in the ER, it can be a challenge, or the challenging pieces can be because there's limited time. Maybe there's a procedure that's immediately happening and I've got to jump in and support right away. There's oftentimes high stress and high emotions with families and patients and high acuity of the situation. So those things can kind of make this feel really challenging, but there's different variables that can make that I'm always trying to focus on or learn that can help guide me in my practice or help me communicate to the staff members to make their care better throughout their hospitalization. So child variables, those are things like their age, their developmental level, temperament, coping skills they've already developed or utilized, their past experiences that have shaped them and made them who they are, and kind of how are they responding to being in the hospital. family variables, those could be more their cultural background or their family structure, who's a part of their family and who's present in the hospital with them and how are they interacting. A lot of times I'm looking at the parents' anxiety level or the things the parents are saying in the room that help me understand maybe how they've shared things with patients. So a lot of times I get parents who they hate IVs themselves, and when we start talking about an IV, they automatically think it's going to go terrible, it's going to be the worst thing ever. And so helping guide them in that this is their first experience with it, and our goal is to try to make that as easy as possible and explain it in language that they'll understand. So kind of looking at those things that are shared with families. And sometimes in the ER, we get kids that are alone. Maybe they're transferred from another hospital and they're going to be alone for an hour. And so how does that impact the care that we're providing until parents can arrive? Sometimes that means extra support from us, or if we need to start an IV, is there a staff member or child life specialist who's available to do a comfort position for that patient during a procedure, those sort of things. So healthcare variables, those are kind of why did they have to come to the hospital? What's their diagnosis and treatment plan? The number of maybe past experiences they've had, or the length of time that maybe they've been in the hospital and they had to turn right around and come back to the ER. All those things kind of fit together to help us know what to plan for, or what maybe past misconceptions or things that they've been dealing with prior to coming in that can help us know going forward that they might struggle with an IV because they've had 2, 3, 4 in the last week. Another healthcare variable we kind of talked about was the staff that we work with can be a variable. So depending on their comfort level with different child life interventions can impact the care that we offer to the patient. So we have staff that's very comfortable with comfort positions and parents holding. We have staff that's not. And so getting to know your staff and kind of knowing where their comfort level lies and making a plan that's best for that child, advocating appropriately, but also knowing that sometimes that might not be the option that you can provide, and that's a variable that's happening in the ER. So moving on, yeah. So I tried to break down my assessment that I do in the ER, and as we were preparing for this, Crystal and I were talking about how I do assessments every day in every single room I walk in, but sometimes it doesn't feel like I'm doing an assessment and then I'm doing an intervention. It kind of feels jumbled and mixed up. So I was trying to get those divided up and what am I exactly looking for when I'm going in rooms. So some observations I'm always looking for are who's present with the patient and how are they interacting. So looking at those cues, the behaviors of the patient and the family. Is there tears? Do they seem relaxed? Are they angry? Kind of getting those feelings, assessing what's happening in their behaviors so that we know moving forward how they might respond to our care. I always look to see if they've brought a comfort item or a toy that might help me in my intervention for distraction, or that maybe would help comfort them when we do procedures. And then I'm always trying to gather a patient's developmental level. So does it match their age? What is their communication ability? Are they at a level where they're communicating easily and understanding what I'm saying and sharing? Or do they seem a little bit behind in their language development? And language barriers too. So some of our kiddos that don't speak English, or maybe it's a second language, trying to figure out, engage, are they understanding what we're saying and just not able to speak our language? Or sometimes they can speak our language just fine and understand us. And then a couple questions I ask in almost every room is just trying to figure out what their previous hospital or procedure experience is and what that was like. was there a lot of stress with that? Or how did their last IV procedure go? Or the last time they got stitches, how did that go and what did that look like? To try to help increase the coping for their time here. And then kind of gauging what patients have been told or what they know already about what's going to happen during their visit. So a lot of times I ask kiddos if they know what we're coming in to do, and sometimes they'll say yes. And then I say, well, what did the doctor tell you we're going to do? And they look at their parent. So they don't always look, or they don't always listen to every provider that's coming in the room. So trying to know that just because they were told in the room, maybe they didn't understand what was being said, but gauging what they know so that I can touch on and in a developmentally appropriate way prepare them for the procedures or admission or whatever is coming up. And then I always involve the patient and family in creating those interventions beyond my gathering of information. Okay. So in the child life world, I feel like APIE is one of those like textbook terms and everybody's kind of heard, but not something we necessarily always talk about in our practice. But I was kind of thinking through how assessment is really foundational to what we do and really guides us to have individualized care for our patients. So I like this little model because it's kind of continual. And so when looking at this, you start with that assessment piece as the first layer, and that's what you're doing when you're gathering information, is helping you make a plan. Now, like I was saying, sometimes that can feel really jumbled because sometimes I'm walking into a room and immediately starting my intervention and kind of moving through that cycle. So I'm starting that intervention, but trying to catch up or play or advocate in a way that I can gather that assessment or the information that I need to know moving forward. Once you kind of gather your information and you're using that intervention for those patients, then you kind of move into that evaluation piece. And evaluation for me is really, what am I going to communicate and who do I need to communicate with? So there's certain information that I would then pass on to the ER staff that I'm with to help guide the next step during the ER visit. Some of that information is what I'm gathering to write in the medical chart or to an email to the primary child life specialist, so that they can follow up or they can understand what their experience was like in the ER. And again, each interaction we have with patients, you're kind of going through the same circle. So it can be continual, it's ongoing. So that's kind of that assessment piece for us.
Okay, thanks, Laura. Yeah, I love that visual that she had of the APIE, thinking of the circle. I sometimes think of that as like the wheels in our head as we're making decisions, because it's constant. It's really constant. And so similarly in chronic care, we look at it very similarly, right? That each interaction is a snapshot. I have my cheesy little picture over here with my Polaroids of every time I'm talking to a parent, every time I'm talking to a child, every text message I receive, every email, every session is a snapshot. And even within the session, what a child says is a snapshot. What a child plays is a snapshot. What is not said, but you feel it. Again, that intuitive gut. A lot of times we know this, so much communication is nonverbal. And so a child's tone of voice, their eye contact or lack of it when they turn away from you, all of those things communicate something. And so we're constantly, our brains are really smart. We're constantly taking in that information and allowing that to influence how we see this child and what we need to be and do with that child from a therapeutic standpoint. These are some key aspects of assessment. Specifically, these are some of the questions at Wonders and Worries that we ask during our parent intake when we're first meeting with a family. And so we'll talk about this a little bit more later of just how do you move from kind of this focused, like question, question, question kind of thing, which our intake paperwork is set up that way so that it's kind of a cheat sheet so that we can reference back and make sure we don't miss anything. But conversationally, hopefully my assessment is much more fluid than that. And certainly as we continue on in our careers, it becomes more fluid. And so some of the key questions that when I'm first meeting with a family that I will ask is just, tell me a little bit about your healthcare experience. Tell me about your medical journey so far, and tell me what your child knows about that. And so that's one of my key questions that I ask. And a lot of times these other pieces get filled in where I don't have to pepper them with 20 questions. I can just ask them 2 or 3, and it feels more like a conversation rather than an interview. And similarly, I'll ask, tell me a little bit about your kids. I want to get to know them through your eyes. And so tell me about their strengths. Tell me about how they're currently coping with what they know and what your concerns are for them. And so I kind of embed multiple questions into one, and then they just kind of tell me about their kids. And so, and then again, if they don't camp out in one area and I want to know more, then I can always add more questions later in the process of meeting with them. But that can help make it feel more fluid as opposed to peppering them with questions. And I think that's really important, especially as Laura was talking about that with her key questions with a child, especially in an ER setting, that environment is so scary. And so even in our setting, we try to make it feel kind of like homey, but they're still meeting a stranger and going to a playroom with a stranger. That's kind of weird. And so kids may feel a little bit anxious. And so we don't want to pepper them with questions. And similarly with parents, they're under a tremendous amount of stress too. And so when we think about brain development, most of the time kids, when they're really young, are in that middle part, that emotional part of their brain, and have a harder time accessing that top part of the brain, the cortex. And that's what we require them to do. We make them hop up there when we're asking them a question. Similarly for parents, if they're super stressed out, they're going to be in that emotional part of their brain. Even though they have more capacity to go up to that higher level of the brain, it's just stressful for them. And so as much as we can pack a punch with the questions that we ask, we want to, so that, and I say pack a punch like that's gentle and sweet, but we want to maximize the questions that we're asking so that we aren't forcing them to that top part of the brain when they're kind of camping out in the middle part. So that will be kind to them as much as you're able to be. But these are certainly things that I will ask if a family doesn't go into as much detail as I want around these particular issues. So developmental age, previous history of support. So I'll ask about OT, speech therapy, physical therapy, counseling. This helps me gather if they've had pre-existing mental health issues, current coping, previous coping. This can oftentimes be a great indicator of you've already walked through a really hard thing, and so we're not starting at square one. And so that can be, especially because we know kids are so resilient, a lot of times that can help, like, because they've learned some skills already. Or it can make it harder because they've already been through one traumatic experience, and so then this is going to be more amplified. So just depending on where the child is, it can go either direction, but it gives me important and valuable information. Family support, and then parents coping. And again, we know that how a parent is coping will impact a child. And so at Wonders and Worries, we provide parenting support, so support around their parenting role, but we don't offer support related to their specific processing of their own illness, but we have amazing partners in the community that we can refer them to. And so we do kind of sneak that in our intakes, just to be able to say, like, hey, you've got to take care of you too, because that is one of the best ways that you can take care of your child. And so we try to help educate them as well. And then again, in our assessments, we're going to be building goals. And so at Wonders and Worries, we have our curriculum, we have kind of our therapeutic goals for every family that walks through our doors. But for the child that's sitting in front of me, the family that's sitting in front of me, I'm going to have different goals for them. If a child is externalizing in their behavior, one of my goals is going to be for them to be able to develop coping strategies to be more in control of their behavior. If a kiddo is internalizing and not communicating, I'm going to be setting a goal of their ability to express feelings more fluidly by the end of our time together. If a family is really cautious and cagey about sharing information with their child, I want them to develop confidence in their ability to do that and for them to have more quantity and quality communication about the medical experience that they're having. Within my care planning, I'm going to be deciding, is the best mode of support one-to-one? Is it family sessions? Is it group sessions? Do I need to be in a more non-directive role with this kiddo, or can I be pretty directive with them based on where they are developmentally and based on where they are coping-wise? Can they handle virtual support? If not, then what are our options currently? And then as we move into seeing clients directly, and then we're going to have both options available, so what's going to be best for them. Frequency of sessions, is it weekly, is it every other week? Expected duration of support, we have our 6-week curriculum, but is that going to be sufficient? And so a lot of times at the intake, I'm going to be prepping the parents for what I think. I'm just going to forewarn y'all that I have furniture being delivered. I have a sign on the door, and so I'm going to just go like this in a second. Is what I'm offering, is it going to be sufficient for meeting their goals? And then when am I going to be meeting for parent consultation with the families so that they know when they're going to get more feedback? Assessing progress. I'm going to be looking for, when clients are working with me, the first time they do something, maybe the first time they approach the medical PlayStation in the playroom, or the first time they say the word cancer, or the first time they shift into asking questions or sharing information more proactively. Those are all evidence of progress. They're getting more comfortable. Is there a shift in themes? And so they might come into session being really angry and aggressive, but then all of a sudden they switch to more of a nurturing role or seeking nurturing. And so again, that is progress. And then there can be utilizing skills outside the playroom. So if a child was really cautious when they first came to see me about talking to their peers about their parent's illness, but now all of a sudden they've shared with their friend. That's huge. That's huge. Or they tell me, yeah, Crystal, I was really ticked off the other day and I was mad, but instead of punching someone, I did some deep breaths, or I took a walk and I didn't punch anybody. Like that's pretty awesome. And so that's progress. Or there can also be just a shift in tone of the play. A lot of times when I'm looking at, is this child ready to end sessions with me? There's a shift from a working type of play to just play. I hate the word just, but like play for play's sake. Like they're just being silly, they're just being fun, they're engaging playfully because they're kids. But they've stopped kind of working on any particular goal that I can identify. And that's usually a key indicator of like, okay, like we're moving in the direction where we can either ease up on sessions and wean off therapeutic support, or they're ready to be done. And then when we're communicating our assessments, we want to communicate early, often, and mindfully. And what I mean by that is that I want to communicate with parents oftentimes right at the intake. I'm going to be sharing with them, hey, based on what you've shared, this is kind of what I think, without even seeing their kid. I think that they are coping most effectively. Sorry, I got distracted. I think they're coping healthily for the circumstances that they're in, for their age, for their temperament. It seems like they're coping effectively. I think this 6-week support is going to help give them more robust skills to navigate, but it seems like they're coping effectively. Or I might say, you know what, I'm a little concerned. I'm not concerned in a, this is super unhealthy, but in a, I'm hopeful that the support that we offer is going to give them all the things that they need, but based on these previous traumas, based on this underlying anxiety, if for some reason our support isn't sufficient, if they need more, then I'll make that recommendation at the end of our time together and give you guys some ideas of where you might seek that support. And then often I want to just set the pace with the parents of when I'm going to be checking in with them. And then of course I want to be mindful and gentle in the way that I'm sharing with them. A lot of times parents can read feedback as criticism. They're being really vulnerable bringing their child to you. And so, and they are oftentimes scared of, I've somehow screwed up my kid. And so we want to be able to encourage them, and we want to tell them what they've done really well. Sometimes that can be hard to find, but the fact that they've brought their kid to you is one great thing, right? Like they're seeking support. They want their kid to be supported. And so find at least one thing that you can encourage them in, even if there's multiple things that you want them to work on. But just recognize that they're under a tremendous amount of stress, and they need to know that they're doing the best they can, and they need to know that you're working with them as a team. And so be gentle in the way that you share those things.
Okay, so we want to kind of shift a little bit and talk about how we grow in our assessment skills. So we all started somewhere. We all had the beginning of our career, or while we were students, that we were learning how to utilize this skill. And then we grow as our career goes on. And so I like how Crystal was talking earlier about making things feel more fluid. And I know when I started out, I had a sheet with, I need to make sure I figure out this and this and this and this and this and this. And it felt like a checklist, and I needed to get all the information. And I would go in rooms and I would feel really choppy and awkward, and nothing was flowing right, or I'd walk out and not gather a single bit of information that I needed. And so there's definitely fails. And I love this little picture and this quote that says, a lot of rookies hit the wall after 50 or 60 games. And when I thought about that, I thought about how many rooms I went in when I first started that it felt awkward or it felt hard. But that as I learned, each room that I went in, I learned something and I grew from there. And so know that if it feels really hard, it's going to get easier the more times you practice. And I think even with just making the assessments and gathering the information that you need, but also communicating assessments. So that can still feel hard for me, of communicating with staff members that maybe are looking at this patient from a medical standpoint and not the psychosocial standpoint, and communicating in a way that doesn't step on toes of medical decisions, but helps them realize kind of where this patient and family is at and why these parents are having the concerns that they're having about the medical plan. And so that can feel hard or intimidating to do. But again, the more you practice and the more you learn how to frame your questions and frame your communication with staff members, the more you're going to grow.
Absolutely. I love that quote, Laura. And yeah, we all start out as rookies, right? And, you know, I think Laura said this earlier in the presentation. I can remember when I first started having students, I had a hard time remembering like why I was doing what I was doing. Like I had to like go back and relearn so that I can teach my students what I was doing. So because I wasn't used to articulating that all the time. And so I think it's good. And kind of we go back to a rookie kind of place in our brain anytime we learn something new. So if you're learning a new skill, if you go to a new training, you're going to go back to where, I love this picture on the right, to where it's like you're going to kind of zoom in to this microscopic, like this is what I'm focused on kind of way of viewing this child or this situation or whatever. And you're focused on this particular skill set that you want to learn and grow in. And so I feel like a lot of rookies do that, right? If they're focused on preparation, if they're focused on medical play, if they're focused on assessment, if they're focused on engaging parents more, it's that zoom kind of focus. And then as we grow in our skill set, it's like we're adding to that broad lens that allows us to see so many different things at the same time, and develops, again, that intuitive gut. And so when I think about the rookie lens, it's a little bit more narrow, a little bit more focused, a little bit more black and white. Oops, there's a typo. And you have to have a lot more effort. It's going to take more energy to focus on that skill. And so if you're new in this and it feels awkward, welcome. It's a career of being awkward and learning. And so just join us. It'll be great. You'll learn. And then for the pro, you're broadening that lens. You have the wide lens. It becomes more fluid, more natural. That's why you start psychoanalyzing your random date or your husband or your child when you get home and you're sitting across from them at dinner. It becomes so natural. It's like your arm. And so it's hard to just cut that off. Which again is a beautiful thing when we think of the therapeutic work, because we can just kind of ooze what we do in the way that we intervene with children and families. So, but it can also sometimes feel messy when you go home. Let's see. Okay, I'm going to pass the baton to Laura to share. We're going to both share an example of how we utilized assessment, what questions we asked, how we gathered that information, and then how that impacted our care plan for that particular child.
Okay, so it was a little bit tricky for me to pick a case example, one, because I have like 20 a day I could choose from, but also trying to pick one that had enough pieces of kind of what we talked about today. So my case example is with a 9-year-old girl that I met in the ER. She was having headaches, vision issues, some hearing loss on one side. So her pediatrician had sent her to an outside imaging center, and at that center was diagnosed with a brain tumor. So when the pediatrician called the parents and told them to come to the ER, they shared that news with them in that moment. So the parents were honest and shared that with this 9-year-old prior to her even getting to the hospital, which a lot of times that's a little bit backwards to what we see in the ER. A lot of times the kids, they come to us, they have their imaging here, they get that diagnosis here, and a lot of times parents aren't ready to, or know how to share that information with their kid, especially a kid as young as 9. But she already had that knowledge walking into the hospital. So I was called by the nurse to help with her IV start and that she was going to have some additional imaging. And so I went to that room to try to prepare her, support her, kind of gather where this family was at. So parents were appropriately tearful, just even upon their arrival. The patient was super bubbly and warm and talked to everyone who entered the room and was not afraid to share that she had a brain tumor, and she was just forthcoming with information for me. She was super detailed, wanted all the information of what was happening. She engaged in preparation for the IV and wanted to know every step and watched the procedure happen. She just was very curious of everything that was going on. And parents shared with me while I was preparing her and we were talking about the IV that they've always been very honest with her. They want her to know what's happening, especially because it's her body and it's happening with her, and that they're just a very close-knit family. So we began talking then about her siblings, and she had 5 siblings. Some of them were older. Some of them were really close in age to her, and I think the youngest one was about 4. This was during COVID time, and so parents were the only family members allowed to be present with her at the hospital. But parents were making phone calls and texting certain people about what was going on. So she went and had her other imaging that confirmed the diagnosis for us, and the doctors shared that it was a really poor prognosis, that the tumor was not operable, that she would maybe be able to get chemo radiation, but they weren't quite sure that was even going to help. So they called the neuro-oncologist, and I kind of just inserted myself back in that room to get to know the family some more and be able to kind of hang out with this 9-year-old girl while her parents met with the doctors to go over all of the information. And while I was hanging out with her, we were just playing Go Fish and coloring and hanging out. She continued to just talk about different things, and she told me that she remembers her oldest brother having a friend who had a brain tumor, and she was like, I remember she was bald and super sick and was always in the hospital. And so I was kind of putting that in the back of my head of, okay, she has some experience. She knows what a brain tumor maybe means and what that is. And so then her older brother called her and was FaceTiming her in the room. And as he was talking to her, he asked her if she remembered her best friend's grandma having a brain tumor. And she seemed a little confused, like, wait, what? I didn't know. And he goes, yeah, isn't that what she had when she died? And immediately when he said it, you could tell he was like, oh, I shouldn't have said that. And he tried to backtrack a little but she was old. This is totally different. Kind of trying to separate those two things. But you could tell in her head, she was then connecting another person she knew who was sick, and also maybe she attended that funeral or knew that this person had died. So when the doctors and her parents came back in the room, the neuro-oncologist was really just preparing her for what was next, that she was going to be admitted, she was going to stay through the weekend until Monday when she'd have some more testing done. And while she asked her if she had any questions, this girl said, I don't think I'm gonna die from this. She goes, I think if I was gonna die, I would feel worse. And so the neuro-oncologist just kind of said, we're gonna take really good care of you. We're gonna focus kind of a day at a time. And what I want you and your parents to be able to stay here, relax for the next day, and we'll touch base on Monday of what's next. To try to refocus her to just focus on what's now. But that really, the parents became really tearful from that because they had just had that conversation with the doctors about her poor prognosis with this. And so I made sure to touch base with the parents of kind of what she had shared with me while they were out of the room. I made sure they knew what child life specialists were, the availability of them, the services we could offer, and had that in a written sheet as well, knowing that their place of emotion was really high and they may not be hearing everything I was saying, but we also talked a lot about how we could help them as they had conversations with the younger siblings who didn't know her diagnosis yet and what that would look like virtually if she was in the hospital, since they weren't allowed to come visit her at the time. So then I made sure to communicate with the parents, and then I also wrote all of that in an email and let the parents know that I'd be communicating with the primary staff that'd be following her. So wrote it in the chart note, wrote it in the email, made sure that people knew what those past experiences were she had with a brain tumor, how she was coping while she was with us, that she seemed very positive, it did very well with procedures and the things currently happening, and then kind of how the parents were handling things and what their family structure was.
Laura, that's a great example. What stands out to me in what you shared is just like her family did such a good job of preparing her. They were a very open family. And then that really, you could tell by the questions and the statements she was making that it gave her those skills to be able to communicate what she was thinking and feeling. And so what a beautiful example of what information and open communication can do, which then makes it less walking on eggshells, but being able to prepare her for having a bald head, or when it does get closer to time, and being able to prepare her for loss and death. So Anyway, that was a great example. Thank you for sharing. And I think especially it highlights for me, I haven't done acute care in a long time, but just the hard work it is to be able to absorb that. It's a really emotional case, and then you don't get to know the rest of the story, or sometimes you do if they come back in through the ER, or if you have good communication with the primary child life specialist. But that's a lot to carry for those of y'all that are working in acute care, to where you do a lot of intense, heavy work on the front end, and then so anyway, a lot of empathy for you.
Yeah, and I kind of liked this example a little bit, just for a lot of people watching that maybe work with families that are dealing with cancer or are inpatient. This is kind of the start, and kind of how it begins, what their journey looks like when it begins. It can feel really overwhelming with a lot of information and really sudden. And then when you meet them the next day or a few days later, kind of what they've gone through in the emergency room.
Yeah, you set an important stage for them to continue to cope and continue to receive care. So it's good work. I'm going to share an example actually from my counseling practice, and so a little bit different. And then I know we're getting close on time, and I'm aware that I'm going to end a few minutes early in case there are questions. So if you've been holding those questions back, go ahead and send them in, and I can make mine brief or longer depending on that. Missy will tell me. But this is a kiddo that I worked with who I was about 14 years old when I first started working with him, and his parents sought out counseling support because he had just been diagnosed with diabetes. He had had previous counseling work before. He had had anxiety, just at baseline, very perfectionistic, which oftentimes can mean anxiety. And so he had had a successful relationship with a therapist previously in a different town where they lived. And that had been supportive for him at that time. And so the family was really proactive, and they called me when he was still in the hospital to set up the initial intake. And so I got him really early in his treatment. And so when I first met with the family, they had just gotten home after that diagnosis, and then we set up sessions after that. And there weren't really any major concerns that they had, except that he had had pre-existing anxiety before. And they recognized that he was going to have to grow up faster, so to speak, that he was going to have to watch what he ate and do his checks of his blood periodically, and really figure out how to adjust medications and all of that kind of stuff. And so there's a lot being added to his plate at a hard age when he's developing independence, but he's not yet independent. And so that was their primary concern for him. When we started working together, he was super chatty, super forthcoming with information. He was kind of like a little adult, and just his personality. He's the oldest sibling, and a super sweet kid. He seemed to be coping in general really well. Like, he would share his frustrations easily. He was super annoyed with the checks. He was very active. And so it was annoying for him that it was impacting some of his activities with soccer and those kinds of things. And so that was the most annoying part. And then the social part of it is like information being shared with friends before he was able to, and just people kind of looking at him like he was an oddball when he was trying so desperately to fit in because he's a teenager. And so just processing through very typical reactions to illness, and then and the frustrations of not being able to get medication to work the way that he had hoped as quickly as he had hoped. And then we just talked about normal everyday things, frustrations with school and frustrations with his annoying brother and frustrations with his parents. And so we started doing that. After a couple sessions, he really shifted gears and was not talking about his diagnosis really at all. He, like, when I would ask about it, he would just say, oh, it's fine. You know, I'm getting used to the highs and lows. You know, I have an appointment next week. We're going to figure out medications that might adjustments that I need to make. But he wasn't really focused on that at all. He focused a little bit more on his relationship with his family. And he kind of seemed, he was polite, so he wasn't going to tell me this, but he seemed annoyed, like, this is one more thing I have to do. And so I, in I think session 3, just asked him, like, how do you think this is going? Do you feel like this is helping support you as you're processing this diagnosis and that sort of thing? He's like, no offense, but like, I'm just not sure I need it. And I was like, no offense taken. Like, that's, I see that you seem to be coping well. And so I can understand as a teenager, you're probably not wanting one extra thing to do, especially when you're managing an illness. And so I said, I have a parent consult set up with your family. We can talk about that. They may disagree. They may be seeing things that I'm not seeing. And because I only see you for, this amount of time once a week or once every other week. And so your parents have a different lens and a different view of you. And so I can't guarantee that they won't say that you need to come back, but I can be a voice for you and communicate what I think you need. And we can maybe adjust the pacing of our sessions. And I just asked him, what's your ideal? Like, if you could go to once a month, just as needed, what would be your preference? And he said, as needed. And so when I met with parents, they had some different things. They were saying, I see these other issues coming up with, but none of them were super glaring. And we just talked about, for a teenager specifically, if he's asking for a break, it will actually long-term set him up for better receiving of support if he has some control in that. He has so many other things that are outside of his control. And so what do you think about taking a break, at least for now, to honor his request? And then these are the things, if they start happening, that you need to check back in for support. And hopefully he'll address that. Like, hopefully he'll be so proactive in his care that he will say, hey, I'm feeling off. I'm feeling like I'm grumpier more often than not, or I feel like I'm struggling with this part of my diagnosis. I want to talk to Crystal. And so anyways, they agreed to talk to him, to get his input, and agreed to kind of take a break from counseling support for a little bit at least. Anyways, in my assessment, of course, it was tuning into what he was saying, how he was coping with his diagnosis, what he was sharing with me, what he was not sharing with me. Like, I could tune into the irritation of, like, I'm talking to you, but just kind of because I have to. And so that was an intuitive gut feeling. That was not something he said, but then I was able to then ask more about that. And then was able to advocate for him in a different kind of way, right? Advocating for not supporting long term, but I don't think he needed it. I think he needed more time with his friends. So anyways, that was an example from my counseling practice. Missy, do you have questions for us? I know we're wrapping up on time.
So there's actually no questions that have come through just yet. So Crystal, if you want to flip to that next slide.
Thank you.
If anyone listening has a question still, certainly go ahead and type it in, and we have Crystal and Laura here still to answer it. First of all, thank you both so much for being here and sharing all this information about assessment and giving us sort of, whether you've done it for a long time or a short time or somewhere in between. I think it's always good to hear it and reframe it for yourself again, and validate what you're doing or get us new spark. So anyway, I appreciate you both. Thank you so much for being here. To those of you who are listening, the QR code in that top corner will take you to the post-assessment if you need a PDU credit. So you can kind of go through that process using that QR code. The other QR code we have here is for our Wonders and Worries activity book. You probably have seen us talk about this or seen it in an email from me. We have that available both in digital copy and hard copy. And I'm biased, but let me tell you what, it is fabulous. And I have a hard copy because I love to touch things. So you certainly can, check that out. We'd love for you to check that out. And you see there in the bottom, the next webinar piece is empty. So I wanted to let you know, first of all, we won't have a WonderChat in May, just like we didn't last year because of the ACLP conference. We want people to be able to enjoy that. But also, moving forward, based on feedback, and we all know this, right? Every time we're on one of these WonderChats, we can use more time, right? It's one of those things, there's always so much to say and so little time. And sometimes we've gotten rushed along the way to try to finish some of our sessions on time. So we decided we're gonna sort of change it up a little bit in order to provide a lengthier opportunity, and also to have our staff be able to sort of prioritize their clinical time and balance this teaching time as well. So beginning in June, we will have our next webinar on June 18th, and it's between two topics, so I'm nailing down those the speakers for that topic. But that will be on June 18th, and we'll be transitioning to a 1.5, so an hour and a half model for our WonderChats. And then we also are going to go every other month. So theoretically, you can still get 9 hours of PDUs in the year versus the 10. But I think that will give us just some more time to really dig in a little bit deeper on these and feel like we've closed the circle, full when we are doing these presentations. So what you can do is participate in ACLP, in May. Watch for my emails, the ones that come out the first Tuesday of each month with the Tuesday tip in it. And that will tell you what the topic is going to be for June. And then I'll have the registration link in there as well. So, and again, if you have any questions ever at all, please reach out to me. I haven't seen any questions come through for Crystal and Laura. So what I will do is thank you all for being here. We will look forward to seeing any of you who can and want to join us in June. And again, many thanks to Crystal and Laura as well. Have a good weekend.
Thanks for tuning in, you guys. Bye.
Yeah. Bye.
Bye-bye.